We're now going to introduce Carrie Marr, also from Tayside, and Carrie, you might just give us a little bit of background about your situation as well before we get started, when you're going to talk about the triple aim, the route to innovation. Thank you.
Thank you. Good morning, everybody. My name is Carrie Marr. I'm the director of what we refer to as TICO, which is the Centre for Organisational Effectiveness in NHS Tayside. And effectively, TICO is a centre for improvement, safety and innovation. And it's a resource centre that supports our 14,000 staff in our healthcare system up in Tayside. Today, what I'd like to talk to you in a wee bit more detail about is our approach to the Triple Aim programme. And what I'd like to do is talk to you about the primary drivers, and I've illustrated them on the jigsaw that you see there, that we've formed as our kind of programme of work around the Triple Aim ambition. And for us in Tayside, we're finding that it's the collective nature of all those primary drivers that's starting to give us some real difference in our outcomes. So, in terms of our improvement journey so far, in Tayside, we've really been trying to look at safety and improvement for some years, starting away back in 2005, when we became the first acute hospital in Scotland to join a consortium of 4 across the UK to look at patient safety. And that got us really interested in improvement, got us really interested in data. As you can see, we started to learn from other organisations in Europe and internationally. And for the first number of years, our improvement and our safety conversation was very orientated to our healthcare system. We were very concentrated on our efforts to look at primary care and secondary care, how we could have more integration in the system, how we could bring safety and improvement to bear. But in the last couple of years, we've shifted our orientation around that. And as well as looking at our healthcare system, what we're finding is that in our Triple Aim work, we're getting much more leverage by thinking about our wider community, our public sector, infrastructure and community, and how we can bring that together. So you'll see that at the moment, we've moved from thinking about our safety and improvement work as being around the boundaries of the organisation to actually thinking about it around the geographical boundaries of our communities that we serve. And I'll talk to you a bit more about that. We've had a clear direction in Scotland and a lot of encouragement to think differently about reshaping how we deliver care, how we deliver services through our public sector. And that's based on the assumption that people are recognising there's a lot of creativity in public service organisations, but we're perhaps not joining forces to really bring that creativity to bear. And I've just offered you a quote from our Finance Minister, John Swinney, who in March came out to ask how we could think more innovatively and creatively and respond to that challenge. We've also, as Jerry was alluding to, we have a 2020 vision for Scotland. And you'll hear more about that in different presentations over the next couple of days. But we have embedded the philosophy of Triple Aim in our 2020 vision. And we believe those 3 dimensions of population health, of resourcing, of experience and quality will serve us well in delivering that vision. And again, against what we call our 12 priority areas in Scotland for action. And happy to give you more details on that later. So, our 4 pillars of reform. We absolutely want to shift towards prevention. Jerry was talking to you about the evidence that's emerging about the connectedness between the outcomes for citizens in our country, which is not just about their health, it's about their lifestyle, it's about their environment, it's about their family. So we want to think more about supporting prevention. We want better integration of public services. And we want to think about how we can design and support a new kind of workforce to help us do that. And think about, as all of us are, what the use of technology might be, particularly if you want to look at home as a care environment and how we could utilise that quite differently. And our strategic aims are the 3 pillars in Triple Aim. We don't waver from them. We find that they're simple, and from a strategic perspective, we build all our improvement and safety work around those strategic aims. So what we've started with is to think about population health. And you heard Maureen this morning refer to the Early Years Collaborative. And the Early Years Collaborative came out of an ambition to think differently for our children. It was thinking about how if we expose children to certain risk factors, we do know and we can predict what the outcome for that population of children could be. And this is just some of the research that Harvard did that was at the back of the Improvement Collaborative, and we have that evidence available for you if you want to see me after today. But we want to use that to think differently. So our Improvement Collaborative for early years is about getting people in the room who've never worked together before, but all have a clear passion and commitment for early years. And this is a picture of Maureen and our Chief Medical Officer, Harry Burns, who came out to see how we were trying to do that differently last year. So they came to visit a couple who had 3 children, but unfortunately the first 2 children were taken into care. This child, who Harry is bouncing on his knee, this child has managed to stay with his family. And the family are getting supported through an innovative family care centre, which particularly works with couples and families who've had histories of substance misuse. But fundamentally thinking about how things have changed for that family and for that child because of the different interventions that health and the local authority have brought to bear around that. And part of that commitment was, you heard there was over 700 people in the room when we got together to commit ourselves to the collaborative, and we've all signed up for it. So we have councils, health, fire, police, voluntary sector, community activists and local citizens who were all in the room at the one time to sign that charter to make a difference. And over the next year or 2, we'll hopefully be able to share with you some of the results from that, which are already looking as if we're going to make a difference. The other area we've focused on in Triple Aim is experience of care, and we've focused entirely on this on older people. Jerry's going to talk a wee bit more about our work in orthopaedics tomorrow, but what we've looked at is how we can change the journey for older people, how we can look after them in an acute setting, but how quickly we could get them back to their home. And we've done that in conjunction with voluntary sector and local government in the region of Angus. We've managed, in the test of change that we did last year, as you see, to make a fundamental difference to length of stay, to readmission rates, and also to step down to care homes. And we've also helpfully reduced bed days. But the other really interesting feedback around that is what older people are saying. Not only are we getting a more efficient pathway, actually this is the pathway that our older people are wanting to have. It's a better experience. Out of it, we've even had one of our physicians, acute physicians, has actually changed from working in the acute hospital 5 days a week and is now working in community for 4 and is following the patients through. So that experience of care and how you can change it is a fundamental lever in Triple Aim. And we've just started last year with colleagues in NHS Grampian an improvement collaborative for older people, where we're looking in our acute hospitals about how we can make care better. And I think picking up really importantly on Maureen's conversation this morning about bringing more empathy and more compassion back in how we look after older people in our acute hospitals. And our driver diagram, which is available to you in the slide set, just sets out what we believe we could do to demonstrate that differently. We've also focused in Triple Aim on waste variation and harm. Jerry's spoken to you about that already this morning, and we've, as you see, and you saw his data as well, We know we've got an opportunity to be more productive, more efficient, but we also know that taking waste and variation out of our system will allow us to invest differently in new models of care. So we have to do the work on waste variation and harm in order to invest in transformational models. So we're doing all of that in our Triple Aim programme. We have our Steps to Better Healthcare programme, and we've done some early work in our medical floor where we looked at 2,000 admissions, we looked at what was coming in the acute hospital, and we found lots of evidence of waste and variation. And I think what really surprised us was finding 40% of our bed days had medically fit people in them. So we had people who wanted to go home, but we couldn't get them home. And that gave us a real momentum to think differently about that. So our older people work is very much on self-care and enablement. It's on prediction. So how can you predict those people who could be in your system in 6 months' time, not who will be in your system tomorrow? And also thinking about how rehabilitation and recovery could be offered in a way that does not produce more demand on your acute hospitals. And these are just some of the outputs that we had on that waste and variation work, which allowed us to draw actual resources out of our acute medical services and invest them in our community modelling. Our third piece on Triple Aim has been around resourcing. And in Scotland, we've been doing some pilot work on what we've called the Integrated Resource Framework. And that was done based on the proposition that the more we understood what each other were doing across the region and across all the organisations in the public service, we started to realise that we were all supporting the same people. So in actual fact, we were all putting our resource into effectively the same 10 streets, the same 100 families. But we were all doing it without talking to each other, without collectively thinking about how we could do this differently, and missing a real opportunity to think about that collective resource and how it could make a difference. So we've done a lot of analysis. We've got many slides on cost cubes, looking at not just how we spend our resource in health, but how we spend our resource in our local government agencies and our voluntary sector, and thinking about how could we look at that very differently. At the moment, we're looking at our elective spend without necessarily thinking about how that connects to care homes and other infrastructure with local government partners. So we've now formed a data sharing partnership. We have our council colleagues, health, fire, police, all round the table together, sharing their data on what we're using to resource care. Not just healthcare, but things like housing, education. And that we're seeing is offering us a real opportunity that's quite different. I was quite taken by Maureen this morning, talking about seeing things differently. And I think, if we were reflecting on our last 2 years, what we see now in terms of how our system of care works, how our communities, what our communities want, what they're asking for, and what we see they need, is completely changed. Triple Aim has caused us to see things differently. And perhaps, as an invitation, that might be something that you could use to see your own regions of care differently as well. So we're going to use our shared understanding about what we have to redirect what we've got differently. And quite importantly, I think, not only to think about integrated models of care, but we also want to start thinking differently about communities. And we've talked there about an assets-based approach. We need to start thinking of the people we serve as assets, not problems. And we need to think about that in a much more positive way, and think differently about how we might work with those citizens and communities to do things different. So the last element of our Triple Aim is to think very differently about what we call civic health. In healthcare, we've probably spent many years talking about community engagement. That's a very different conversation to collectively sitting down with everybody in your locality to talk about what civic health might mean for everybody who's there. And I've given you an opportunity to, in the slide, to see how we're describing it. It may be different for you, but for us, civic health is about being able to nurture and support and sustain that feeling of what people feel is important to them, and indirectly will produce a better outcome on their health. It's a state where everybody sees themselves as stewards of the community. And, I think, to be honest, we've come to this late. We've learned a lot about this from local government colleagues who are helping us to think differently about it. But we're also learning a lot from our local communities who actually know this better than us. And as a test of change, for the last year, we have brought into the organisational development team in the centre 2 community activists. And we call them our disruptive innovators. They don't work for the healthcare system. We've given them freedom to go out and talk to communities to see how we could do things differently. And we're at a point now, a year on, where we've got permission from 2 communities, one in Blairgowrie and one in Carrie, both in Tayside, to work with them. And this is not about agencies going in and doing 2. This is about those individuals who are active in community life starting to invite us in to talk to them about how we can grow and nurture their civic health. And we're quite excited about that, because it's a very, very different conversation for us in healthcare to have, and not one we would have had 2-3 years ago. But we believe that the potential around this is enormous. And effectively, and Margaret Wheatley used this quote in one of her books, that if a community discovers what matters to it, what's important to it, you can engage with that community in a different way. And it's not for us to determine what that community should care about. So there's a real opportunity there to think about differently. And lastly, I suppose I was thinking about, in terms of what we've done around Triple Aim, how we've brought what we've brought together. What has caused that to happen? And we've started to talk about guiding coalitions. Coalitions for change. But coalitions because we're not talking about hierarchies. We're not talking about structures. And often in healthcare, that tends to be our kind of preferred position. We want to talk about changing the structure of things. We want to change how we organise it, rather than actually, much more importantly, have a conversation about our ambition for change, the culture that would support it, and how you can get people in a coalition to think differently about that. Now, I believe we've started that conversation in Tayside. I don't believe we've finished it. I believe it's an ongoing one. But everybody in the locality is a member of that coalition, and everybody is a leader in their own right of that coalition. And I thought the quote at the bottom there was quite apt. I think at times we have come to problems thinking like mechanics, instead of coming to issues around communities and community need and thinking about assets-based approaches, and thinking about what Zengi talks about as gardening, nurturing, sustaining, creating. We've seen quite a lot of good work come out of a coalition approach. I've talked to you a bit about our outcomes on Triple Aim. We have an improvement team that works across all of the public sector in Tayside, and it's represented by all the agencies, so we have a joint effort on improvement, and we have a joint plan to build capacity and capability across all of the organisations. And Heather's going to talk a wee bit more about that next. And we've also done things like formed coaching alliances. So we're starting to work more and more collectively, and starting to learn a lot more about each other's worlds. We're seeing good outcomes starting to come out of the work we're doing. We are optimistic that this time next year, given all of those drivers, we'll actually be able to tell you even more about our story on our Triple Aim journey. Okay, thank you.
Carrie, thank you very much. That's a very powerful discussion about the strength of the triple aim in providing focus for our work. And the triple aim is, in some areas around the world, is starting to legitimise population health and our work as healthcare systems in a way that has been a little academic in the past. But the other thing we just heard was the power of actually partnering and relationships and responding to what the community itself is wanting rather than what we think they ought to be wanting, which is a pretty significant jump for a healthcare system. Even if we intellectually know we should make that jump, it's in our DNA not to do that very naturally. So, questions or comments from the Twitter feed?
We've got a couple of questions here. First of all, what was your biggest barrier to getting health, social, ambulance, mental, fire and police to share their data?
Two things, probably. Firstly, that historically we probably all come to the table holding on and protecting our data, and we've not come to the table with a view we're going to be fairly open with it. I think the more we talked about what we could get from sharing it, the more people understood that we could create value. Yeah. But the biggest barrier was that even with the best will in the world, and Jerry was talking about will as well as ideas, with the will there, the systems were not built in such a way to make it happen. So we've had to go back to basics on some of it, but we've actually formed a population health centre where we've got a data expert from each of the organisations are now in a joint team, and they're trying to resolve some of those issues. So the will's there, but the IT systems sometimes don't work so fast.
So just to follow that question before you get to the next one, some people may have had the experience where they convene those meetings and people attend from the different agencies, but they don't really participate. So they turn up, but they don't actually engage in a meaningful way. How did you make sure that happened? How did you help that to happen?
Okay, so with any change effort, personally, I firmly believe, and the evidence shows us, that if the time you take to create the conditions for change to happen is worth its weight in gold. So before those data experts got in the room and started talking, we actually spent a number of months as a leadership group talking through our ambition, talking through our commitment. So those individuals knew they were in the room with the sponsorship of the leaders and the executives of their organisation to do that, and to be different. And also that we were encouraging them to be innovative.
Right, so significant pre-work.
Absolutely.
Yes, a little guidance. There was a second Twitter question, I think.
Yeah, that's another one. What are your top system measures?
What are your top system measures?
Well, it's the health service. We've got about 240 of them. We've got, I suppose, we've had a single outcome agreement, which we have been looking at and developing. It's a requirement through our community planning partnerships. And so what we're trying to do is blend together those outcomes that in the past might have sat in community planning and some in healthcare, and bring together a much more distinct set of shared outcomes. So our SOA is still there. We are building in outcomes linked to triple aim, and happy to share with anyone who wants after this what the detail of that looks like.
Other questions or comments from the audience? The old-fashioned way. So if there are not, Carrie, thank you very much indeed, and we'll be going on to the next presentation.